The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we are so lucky to have Dr. Jessica Staszak here to review the management of all things related to trauma of the head, neck, and spine. Dr. Staszak is a trauma and critical care surgeon at Washington University in St. Louis who completed fellowships in both pediatric and adult surgical critical care. Thank you for being here.
Thank you very much for having me. I'm looking forward to it.
My name is Nicole Santucci, and I'm a general surgery resident and will be your host for this episode. So let's dive right into our case scenario to help guide our discussion today. Okay, Dr. Staszak, you are the trauma junior on your team, and you receive a level 1 page that states 76-year-old male, fall from 3 feet, confused on scene, laceration to face on Eliquis, GCS 10, ETA 5 minutes. How do you start your initial evaluation in the trauma bay?
So every trauma is going to start the same way with your primary survey and the ABCs. We assess airway, breathing, and circulation in that order every time. It's really important to remember that you cannot move on to the next component of the ABCs until you've met those criteria of being intact and acceptable. So in our scenario, our patient is speaking and protecting their airway, so we move on to breathing. He has bilateral breath sounds, which is great, and palpable femoral pulses, so circulation is relatively intact. We then can move on to determining the Glasgow Coma Scale, or GCS, which is another part of the primary survey, sort of part of the D for disability, especially when we're concerned about a potential neurologic injury. GCS runs on a scale from 3 to 15 and has 3 different components. First, the eye-opening response, which is a maximum of 4 points, a verbal response, maximum of 5 points, and motor response, which gives you up to 6 points.
Okay, so let's say our patient in the trauma bay that we're evaluating opens their eyes to voice, so gets an I score of 3, can say words but doesn't have appropriate responses, so gets a verbal score of 4, and then has purposeful movements to pain, so motor score of 5. He gets a GCS 11. So what do we do next?
You can then move on to the secondary survey because based on your GCS, you don't have to automatically consider intubation. You perform your head-to-toe evaluation of your secondary survey to assess all other injuries, which includes a complete neurologic examination. We know that this patient has a laceration on his occiput based on the trauma page, but we also want to evaluate any bony deformities or step-offs that could indicate facial or skull fractures, so anteriorly and posteriorly. We evaluate the orbit and the globe structure, thinking about things like unilateral pupil dilation that could be an early sign of brain herniation or increased ICP, periorbital hematomas or the raccoon eye sign that could signify a skull base fracture, and then also looking for ocular entrapment from different types of facial fractures. Next, we examine the nose and the ears, where ruptured tympanic membrane, hemotympanum, which is blood behind your TM, or otorrhea can also be signs of basal skull fractures. Oral exam can identify missing dentition, foreign bodies, or soft tissue injuries. And finally, all patients with blunt trauma and concern for cervical spine injury should have C-spine immobilization. Evaluate your C-spine before applying your C-collar by palpating for deformities and posterior midline tenderness. If the patient already has a C-collar in place, it's important to have a second examiner hold C-spine precautions before the collar is undone so that you can reach behind and perform your examination. You then will go on to complete the remainder of your secondary survey below the neck, but that's beyond the scope of today's topic.
Awesome. So let's recap what we know so far. Our patient is a 76-year-old man. He tripped and fell 3 feet and hit his head. He's on Eliquis for his AFib. His last dose was this morning. His primary survey was intact, GCS of 11. His secondary survey was notable for an 8-centimeter laceration to his right forehead that's hemostatic, and he has some midline tenderness to palpation in his C-spine. He had a C-collar on arrival to the trauma bay, and we reevaluated his C-spine in the bay. So what next?
Well, next I think we can go to the CT scanner. As long as he's hemodynamically stable, it's okay to pack up your patient and move on to the next steps. So evaluating his injuries will definitely include non-contrasted CT of the head, face, and the C-spine. Any blunt traumas with a GCS of less than 13 or a decline in neurologic exam from the time he enters medical care warrants a non-contrasted head CT. So please go ahead and review our show notes for the Canadian CT head rule that does help determine which patients with a GCS of 13 to 15 warrant a head CT. But because our patient is on anticoagulation, we use all of these above guidelines for determining what imaging he would need.
So what types of head injuries might we be concerned about in our patient, and what would be their respective imaging findings on our non-con head CT?
There are a few. The first, of course, would be an epidural hematoma that is one of the most concerning reasons that a neurosurgeon would need to be involved early for operative decision making. These have the classic lucid interval that a patient might present with decreased GCS, come back, wake up, look a little bit more normal, and then are again followed by rapid deterioration. And those usually occur from a laceration of the middle meningeal artery. On CT scan, you see a biconvex hyperdensity that will stay within suture lines. The next type and very common injury that we see are acute subdural hematomas, usually seen in an acceleration or deceleration trauma with shearing or tearing forces that affect the small bridging veins draining into the dural sinuses. On CT, these look like a hyperdense crescent signifying blood between the dura and the surface of the brain. Now, the chronic subdural hematomas, which we'll also often see in patients that are asymptomatic but often on blood thinners of some variety, present with focal neurologic deficits, changes in mental status, and/or seizures. These have a delayed manifestation, usually days to weeks after the initial head trauma. On CT, these are hypodense crescent collections between the dura and the brain, but it is hypodense now because it is a chronic finding with old blood. The next finding we could see are cerebral contusions that present with a coup-contre-coup pattern, meaning that there's an injury to the cortex in the site of impact, but then also where the brain encounters on the opposite side of skull after impact. So on CT, these are small and punctate hyperdensities, usually in the basal, frontal, and temporal lobes. An MRI shows these small contusions the best. And then finally, intraparenchymal hemorrhages occur when larger cerebral vessels are lacerated. And on CT, these are exactly as they sound within the brain parenchyma, and they're large areas of hyperdensity, usually with a hypodensity surrounding them that is an area of edema.
Thank you for that awesome overview of these different types of injuries. So what did the head CT for our patient show, and what do we do next?
In this case, our trauma patient has an acute subdural hematoma on his head CT, and so neurosurgery is consulted emergently in the emergency department. The initial keys to manage the head injuries are first, preserving cerebral perfusion by managing intracranial pressure and cerebral perfusion pressure. You want your intracranial pressure to be less than 20 millimeters of mercury and your cerebral perfusion pressure to have a map of 60 to 70 millimeters of mercury. You can monitor ICP directly using a bolt, and you can manage your ICPs using sedation, pain control, diuretics, elevating the head of bed, and hyperventilation. In patients that you are able to examine and don't necessarily need intracranial pressure monitoring, you still want to use those same adjuncts to be able to assure yourself that they're not having mental status changes because you are managing their ICPs. The other thing is that this patient is also on Eliquis, so we have to think about correcting his coagulopathy to minimize further bleeding or worsening of his head bleed. An important question to ask in trauma workup is when this patient's last dose of medication was given so we can reverse the anticoagulant if possible. Our goal is to have an INR of less than or equal to 1.4, a PTT that is normal or less than 40, and platelets greater than 100,000. Thromboelastography, or TEG, will also help us provide more targeted metrics for resuscitation that we'll often use, particularly in polytrauma patients.
Thank you for that awesome case. Now on to our second case. So you receive a level 1 page that states 32-year-old male, stab wound to the neck, GCS 15, ETA 5 minutes. How do we start the trauma workup for this patient?
So just like in our first case, again, we always start with our primary survey and assess the ABCs, airway, breathing, and circulation. Our A is particularly important when there is concern for penetrating neck injury or an injury that violates the platysma because of the high risk for airway injury or compromise. Evidence of shock, pulsatile bleeding, expanding hematoma, audible bruit or palpable thrill, and airway compromise are hard signs of injury that would indicate we should immediately secure the airway and proceed with surgical exploration. Sometimes even securing the airway is best done in the operating room and should be a quick discussion between you and your ER providers and everybody's comfort with obtaining a solid airway. Softer signs of injury include minor hemoptysis, hematemesis, a non-expanding hematoma, dysphonia, and dysphagia. So on secondary survey, when we are reevaluating and doing our head-to-toe trauma evaluation, we look for these signs of injury as well as other injuries and then return our focus to our stab wound.
How can we classify or categorize neck wounds to help us think about workup and management?
So all neck wounds are classified by the zone of injury, and we base these on anatomic landmarks that help us with both management and operative approach. So zone 1 injuries are injuries that are near the thoracic inlet that extends from the manubrium up to the cricoid cartilage. Zone 2 injuries are the most common and consist of basically the mid-neck from the cricoid cartilage to the angle of the mandible. And then zone 3 is the upper neck from the angle of the mandible to the base of the skull. And if you think about that, zone 1 is closest closest to the chest. Zone 3 is closest to the chin, and so we consider these an inferior to superior.
Awesome. So to recap, we have a 32-year-old male with an isolated stab wound to zone 2 of the neck. The primary survey was intact, and the patient's protecting their airway with no hard signs of injury. They do, however, have clear violation of the platysma and dysphonia. What do we do next?
Since this patient is hemodynamically stable, we can actually proceed to CT angiography to determine the trajectory of the injury and plan the operative approach. Most patients with zone 2 injuries historically go directly to the operating room for neck exploration. But with the advent of really excellent CT scanning and angiography ability, we actually can save many patients a true neck exploration that have zone 2 injuries. The other thing to remember, though, is if your patient is unstable in any way or has a hard sign of injury, you do not have to stop at the CT scanner, and it in fact is very important. If they're actively bleeding or you have concerns for their airway, you have concerns for tamponade, at minimum you need to secure their airway before going to the CT scanner and consider just going straight to the OR for an emergent neck exploration instead of making that pit stop.
What is the operative approach for a zone 2 injury like we have in this patient?
From an operative standpoint, we have to consider all of the things that reside within zone 2. These patients do often show up with dysphonia and dysphagia, so we for sure need to look at and rule out injury to both the trachea and the esophagus. So we will typically do at least a direct laryngoscopy, particularly while they're being intubated. We may consult our ENT colleagues for a flexible laryngoscopy if the injury is zone 2 to zone 3, or perform a bronchoscopy ourselves in the operating room. We also will perform an EGD to rule out esophageal injury. But if you're doing a complete neck exploration, your operative approach is going to be through a transverse cervical collar incision or an anterior sternocleidomastoid incision. You carry down through the platysma, and then initially you should encounter the internal jugular vein and the carotid sheath. You should dissect those out, particularly in the patient who has an expanding hematoma. You'll likely expect to find your first sign of injury there. During that dissection, you do need to pay special attention to preserve all of the cranial nerves you encounter, including the vagus, glossopharyngeal, hypoglossal, marginal mandibular branch of the facial nerve. And then once you are done with that, typically you'll perform the EGD and bronchoscopy if you didn't start with that.
Now, what if this were a zone 1 or a zone 3 injury?
So zone 1 injuries typically have to be approached by a median sternotomy and possible extension along the SCM or the supraclavicular, but are often managed by thoracic colleagues. Zone 3 injuries are often managed by our ENT colleagues because they're very high in the neck and may include salivary glands and other things that are not necessarily in all general surgeons' scope of practice. And truly, if there's a vascular injury within zone 3, the preferred approach is often endovascularly because an open operative approach could require pretty severe measures like dislocating the mandible for access.
Thank you, Dr. Staszak, so much for being with us today. We got through a ton of great information about management of head, neck, and spinal trauma. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, and a full review of head, neck, and spinal trauma can be found in the Washington Manual of Surgery, Chapter 6.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.